few moments. Welcome, everyone. Thanks for joining us for the program today. We're going to get started in just a moment. Hi, everyone. We'll get started in just a moment. Thanks for being with us for today's webinar. Well, welcome, everyone. I am Michael Morella, Managing Editor at U.S. News and World Report. For today's webinar, we're examining battling burnout while building the health workforce of the future. Today's session is part of our ongoing Healthcare of Tomorrow virtual event series. You can learn more about today's speakers and some other events we have coming up at usnews.com/healthcareoftomorrow. We are recording video of today's program, as well as simulcasting on several U.S. News social media channels. I'm very excited to welcome our distinguished panel. With us today are Dr. Erin Frere, Director of the Carolina Health Workforce Research Center at the University of North Carolina, Chapel Hill, where she's also an associate professor in the Department of Family Medicine. Dr. Ernest Grant, President of the American Nurses Association. Will Patterson, CEO and co-founder of CareRev. And Dr. Scott Rissmiller, the Enterprise Executive Vice President and Chief Physician Executive for Atrium Health. Now, before I turn it over to our moderator, let me just say that if you have questions, please feel free to pose them in the Q&A section on your screen. We'll review those and try to incorporate what we can during the hour. Now over to my colleague, Liz Whitehead, Managing Editor of Events at U.S. News, to get into the discussion. Liz?
Thanks, Michael, and thanks to the audience for joining us. Burnout has been one of the most intractable problems in healthcare for decades, a challenge only made more critical by the pandemic. We feel really fortunate to have such an outstanding panel to help us get our arms around this complex issue and to identify the kinds of solutions and best practices to take us forward. I'd like to just start out quickly by having each panelist tell us about their current roles to understand the perspectives they bring. Dr. Scott Rissmiller can start us off. Scott?
Great. And I'd like to start by saying thank you to U.S. News for having us and everyone for joining. This is such an incredibly important topic. So I am Scott Rissmiller. I am our Chief Physician Executive at Atrium Health. I have been in this role for the past 3.5 years, but I have been with Atrium Health for 25 years now. I'm an internal medicine physician, and that is my clinical background and practice. So glad to be here, and thank you for having me.
Thank you, Scott. I'll turn now to Dr. Ernest Grant. Ernest?
Well, thank you, Liz. And just like Scott, I want to say thanks for the opportunity to be with you and with this distinguished panel. I'm Dr. Ernest Grant, President of the American Nurses Association, which represents the interest of the nation's 4.3 million registered nurses. My background, though, is in fire and burns, and I spent 36 years at the University of North Carolina hospitals and the School of Nursing there. So excited to be here.
Thank you. Dr. Erin Frere.
Thank you, Liz, and hello all. It is absolutely a pleasure to be here, especially discussing these absolutely critical issues. I'm a health workforce researcher at the University of North Carolina at Chapel Hill, where I run a workforce center. And the goal of our center is really to produce research and data to inform state and national policy. Our current work is really focused on what we're calling trying to shift the narrative from a health workforce to a workforce for health. So what does that workforce for health look like? And a workforce for health is the workforce for patient care. It's the health of the providers themselves and the health of the provider system and communities. So just a pleasure to be here discussing these issues today.
Thank you. And we'll turn to Will Patterson. Will?
Thanks, Liz. So I'm lucky enough to have been a trauma ICU nurse working around the country prior to starting this company. Back in 2014, I really wanted to build a future that worked for me and other nurses that I worked for, and a lot of that had to do with flexibility in our work-life balance. And so I started, co-founded CareRev, which is a marketplace, a labor marketplace that connects healthcare systems directly with local labor that can work on demand. We also provide workforce technology that incorporates machine learning to help healthcare systems smart in a more flexible and smarter way. So thanks for having me. Appreciate it.
Thank you. So to tackle burnout, I think it's important to just take a step back and get our arms around the magnitude of the problems and the key drivers for it, and then we can move into some solutions to addressing these issues. Scott, at Atrium Health, coming out of the pandemic, is burnout showing up more among some subsets of your healthcare personnel more than others? Is the situation better than, say, 18 months ago? Or is it the same or worse?
Yeah, great question. I think we were all very hopeful coming out of the pandemic that we were going to have some time to sort of reflect and recover. And we all know, I just did a presentation on this not too long ago, and for the slide I chose, I'm a big Rocky fan. Sorry, that's a little bit of a useless information about me, but I had a picture of him sitting on in the corner, all beat up, getting ready to come out for the next round. And I said, this is us coming out of the pandemic. And then the next picture was Rocky coming out and getting punched right back in the face. And in many ways, it feels like that, unfortunately. So, I think that in many ways, we actually, across the country in healthcare, are in a tougher place, because I think we are hopeful that we would have time to recover. And healthcare is in continual change and flux, and is changing even more rapidly with the staffing challenges and other things that we have now, and the financial challenges that in healthcare across the country. But I am incredibly grateful, though, that prior to the pandemic, we did so much work at Atrium in regards to the culture and resiliency of our clinicians. And a lot of that was very basic stuff, like opening clear lines of communication and acting upon it. And then we built upon that based the feedback from our team. So I think at Atrium Health, I can say we're tired. Our teams are tired. They are hopeful for better days ahead, but we are seeing them still very up for the challenges. And that's because of the culture work we have put in place over the past several years.
And Scott, I absolutely want to give you a chance to talk more about your resiliency programs at Atrium Health as we move into the conversation. Thank you for raising that. Ernest, obviously nurses are the backbone of any healthcare system, and we have a real problem right now with shortages around the country. Can you give us, I think, the concerning numbers about attrition rates and retirement rates versus how many nurses are graduating from nursing school right now? Where does that put us?
Certainly. That's a really great question. Right now, we are seeing, we graduate probably about 200,000 nurses a year from this combination university and associate degree programs, as well as the few diploma programs that are there. However, we already know that we're already short about 500,000 currently as we are speaking, and it's estimated to be about 1 to 1.5 million over the next year to 5 years. It's going to be people my age, the latter part of the baby boomers, as we're beginning to retire. That's going to make an even bigger dent in the shortage as well. And a lot of them, as I'm sure your audience has probably read over at the peak of the pandemic, a lot of older nurses decided to retire early because of one, when we first encountered the pandemic, it was older adults who were being inflicted with the virus more often than other individuals. Plus, they didn't want to perhaps consider the possibility of taking the virus home to their family members as well. But I think also it's important to understand the root cause of the burnout is COVID just exacerbated it. This was something that we were seeing on the horizon before. And like Scott had mentioned, obviously Atrium being very progressive and recognizing that and putting in measures to ensure that their staff has resilience. I'd say probably about 90% of healthcare facilities around the country, and that's not only acute care, that's long-term care, community focused as well, failed to do that. So it's like they got hit by a big, stumbling block when the great resignation, if you will, among nurses began to happen. Actually, our American Nurses Foundation just completed a survey in June. We've been doing a series of Pulse of the Nation surveys since COVID came along. And just this past June, we surveyed over 11,800 nurses and found that 42% said that they considered their work environment healthy. Now, that doesn't account for the other, 58% that would consider their workplace unhealthy. And what we've been hearing from nurses, the biggest concern is they want to work in a safe, healthy environment. And, there was a Press Ganey survey released about 3 weeks ago that said every hour, 2 nurses are assaulted across the country every day. That's from patients patients' families or even their nurse colleagues. So that too contributes to, part of why, nurses are having these, these rates of burnout. The attrition rates are, continuing to fall because when they do report these incidents, they do not feel supported by their employer. And of course, that sends a message to other nurses when something like that has happened, that if that were to happen to other nurses, perhaps they don't feel that they would be supported as well. So those are just some of the things. We'll obviously be talking about some more, but that's just to give you a couple of little tidbits there about some of why and how burnout is affecting nurses.
Yeah, thank you. And the workplace violence problem is a very serious one. So we absolutely are going to come back to that. Thank you for raising that. Will, you have a really helpful perspective because you're talking to institutions around the country. How would you characterize the impact of this ongoing staffing crisis on operations? And what differences are you seeing now than, say, 2020, before the pandemic was well underway, versus now?
For sure. I mean, this has been a problem prior to 2020. I mean, when I was in nursing school at Duke, we were talking about this, right? There's a shortage. As soon as I entered the workplace, you could see evidence that there was a shortage then. I think the pandemic just really highlighted it. And now here we are in a place where 2 in 5 nurses are saying they intend to leave nursing within 2 years. I believe there's going to be 88.5 million Americans who are 65 and up by 2050. So if we don't have nurses to take care of, my parents or myself when I'm older, that's a huge problem for all of us. And then you have this complete change in the way people want to work. And you're seeing this across many industries. You've seen this in the energy and oil and gas industry. You've seen this in warehouses. This on-demand workforce is the way the newer generation wants to work. And so by 2023, on-demand workers are going to make up 50% of the entire U.S. workforce. So what does that mean for healthcare and healthcare systems? Well, healthcare systems are built on almost like an industrial way of operating, and it's a really hard industry to change too, right? Because you have these patients that are in the hospital, you want consistency of care, but what we're hearing now is the workforce is saying, hey, we don't want to work for the same hospital for 20 years anymore. We want to enjoy our lives. Most of these folks, I think 4.6 million or 30% of healthcare workers have children under the age of 14. They want to spend time with their kids, and they really want a flexible work environment. So as far as operating in healthcare systems goes, prior to 2020 to now, what I've seen as our conversations with healthcare executives go is before 2020, they're like, nothing's changing. We're not going to change. Everything's good, right? We have other problems that are more important right now. And now the good news is what we're seeing is, everybody's aligned. We have to change. And so now it's not whether we change, it's how do we change and how do we get there and what's the best way to get there?
Liz, if I could, before
Yes.
you ask the next question, I'd just like to add to what Will had just stated, and that is to maybe change the term from a nursing shortage to a nursing crisis. September of last year, I wrote an 8-page letter to Health and Human Services Secretary Becerra, asking him to declare this a crisis, not a shortage, because I've been a nurse 40 some years, and every other year or so, there's been what we would consider a shortage, but nothing to what we're seeing now. We're in a crisis mode and still will be in that mode. It's not necessarily just reflective of the pandemic that we're coming out of, but this has been building and building, and we have virtually hit the wall. And I still have yet to hear from Secretary Becerra 1 year later. And in that letter, I suggested solutions. Bring everyone to the table. Let's look at short and long-term goals that we can all reach. But we still have yet to get some work done on that. But this is a crisis. This is not a shortage, and I fear for the American healthcare system if this is allowed to continue the way it is going. And I'm sorry to interrupt. I know you've got
No. Thank you.
That's good.
To Aaron, but I really think the audience needs to understand how severe this is. When we say shortage, maybe it's taken go out and recruit some more. crisis means we're in dire mode, like the patient needs to be defibrillated, if you will. And, and where are where's the IED, the defibrillator to come along and, provide that extra charge that is needed.
That's all great. And we're going to get very much into the how to deal with this crisis much more effectively. Aaron, I just wanted to give you a chance to get in here. You've talked about the pandemic being a stress test for the healthcare system. You've also looked at how other countries are dealing with their issues in these areas. How is the US compared? Are other countries managing it better, not managing it better? And also, please feel free to pick up on any of the points of your fellow panelists.
Absolutely. So I'm really taken with the New England Journal of Medicine paper that our Surgeon General wrote on burnout, where he really pointed out that burnout manifests itself in individuals, but it's rooted in systems. And that's what this conversation has been about. That burnout, is a function of multiple system levels, the organizational level, the staffing, people feeling excessively overworked, that nurses are being pulled in many directions, many of which are because we don't have, for example, transport or housekeeping staff. So nurses are doing things that they don't need to do. They're transporting patients around the building, which means that they don't, they're not available to staff ICU beds, Scott, which means that your CRNAs may be holding people at post-op 60 to 90 minutes in post-op because there's no bed to discharge to. So there's these organizational staffing things. And when I look at other countries, what fundamentally comes across to me is no one's doing it. There's no magic bullet here, but there are structural things. And when you compare countries and with very different healthcare systems, the structural pieces come to play, right? So it's interesting that, for example, US physicians are feeling the burden of documentation, EHR documentation, but nurses as well in documentation compared to, say, our British colleagues who don't report that as a pressure. In Germany, colleagues and physician colleagues are talking about the pressures of for-profit medicine. We're not really talking about that in the US. And so it's this interesting sort of juxtaposition that across countries, it really is a structural element. But let's sort of think about what you all have talked about. There's the individual level burnout manifestation. And one of the things I want to say there is let's reframe it from burnout to wellness. So one of the reasons people feel burned out is that they don't feel valued. So let's change it to wellness. How do we promote wellness at the individual level? What are the organizational structures? But professions, frankly, play a role here. Professional licensing bodies, professional training institutions that foster a culture of, in licensing bodies, some nurses and some others are afraid to report they're not well because they're afraid of discipline. So there's a lot that we could be doing in the professional level as well. And then at the societal level too, hopefully we'll be able to talk about the fact that payment models really matter. Sort of if you're on this fee-for-service treadmill and you're having to document everything, that causes moral distress and burnout. And so I just want to sort of unpack this conversation like any true academic with a conceptual framework that is multifaceted, individual, organizational. And this is really drawing on some work of a colleague of mine, Dr. Tanya Jenkins, who's a sociologist at UNC. So those are some of the things that we see across country comparisons to how the US is comparing to other colleagues.
So you've all raised really important points. And I think we need to talk about wellness, mental health, resilience training. We need to talk about this, the structural, how work is handled and how it can be restructured, all these issues. So I'd like to turn it to Scott to start us off. Just in the immediate term with the stress staff, how are you handling behavioral health, resilience training? And then we can also then move into the structural issues about how work's distributed.
Absolutely. So, I'm a big believer and I struggle with resilience training. I'll start there because if you look at people who go into healthcare, our nurses, our physicians, IAPPs, they are some of the most resilient people you will ever meet, or they never would have made it into healthcare. I hear a lot of people talking about resilience training, and I know what they mean by that. But I think a lot of times what people hear when they hear that is you just need to get a little tougher. Mm-hmm. And that is absolutely not the answer or the solution, because they are incredibly resilient. It's my belief from a physician, APP, and nurse standpoint that in healthcare over the past several decades, we've just layered too much on top of people. And it's gotten in between why they went into healthcare, which is to care for that person sitting in front of them. And to me, that if we get back to that, that is one of the major answers to burnout. Now, That sounds simple. It's not, right? So, you know, when I got in my role as chief physician executive 3.5 years ago, fortunately had about a year head start on the pandemic. You know, I've really focused on what we call best place of care, and it became an enterprise-wide initiative for us. But it's based off one of my favorite quotes, which is from Napoleon, which is a leader's job is to define reality and then give hope. And, you know, we have a lot of defining reality going on right now, and we have in healthcare for a long time, and the reality isn't always rosy. But I thought it was very important for us to really give hope to our practitioners, our physicians, APP nurses, and others that better day was coming, and that we were going to focus on those things that were getting in between them and why they went into healthcare, that relationship with the patient in front of them. So Best Place Care was launched, and it was focused initially on physicians and APPs, and now we're expanding it to nurses and others. But it was really focused on practical things that we could do to make their day-to-day lives better. And it broke down, I'll just real quick, into 3 areas. The first one was sort of workflow efficiency. So in the hospital or in their offices, how do we maximize the time the patient and the clinician have face-to-face talking about important stuff and doing why they went into healthcare? The second is really about the care provider experience and that sort of professional fulfillment and growth and working in teams and other kind of things around that. And then the third one was culture and well-being. And that was getting back to creating sort of that sense of family, that sense of team belonging, and a big piece of that we launched prior to the pandemic was a very transparent bidirectional communication strategy. And if I were to say one thing that helped us the greatest through the pandemic was when it started, it was that. It was because there was so much unknown at the beginning of the pandemic, and there's so much unknown now, even with, okay, how are we going to do on staffing and other things? And our approach, my approach to communication was, if we're not in a good place, we're going to say that, and we're going to be clear about it. But we're going to talk about what we're looking at doing and how we're looking to solve it. And then we're going to not just ask, we are going to beg for feedback from our team. And then we're going to close that loop and act on it. So during the pandemic, we started what was called a daily brief. It was a long page of everything we knew about staffing, PPE, transmission, treatments, everything else. It went out every single day for 2.5 years during the pandemic, from myself and from my deputy chief physician executive. I did twice a week, just off the cuff calls with all of our physician and APPs and admin and nurses across the enterprise. Unscripted, just talking about where we were and asking for feedback and giving that transparent thing. We have monthly, and they're still going on, webinars around wellness, how to take care of yourself, how to endure, mindfulness, different kind of things that are recorded, and anybody can listen to it at any time. And then we also, though, for those that needed more help, we created and made it very easy. It's on everyone's email that when it goes out, it's a little QR code. You click on it with your phone, and up comes resources, all the way from, you know, the usual stuff, like it starts obviously with 911 and those type of things for people who need it. But then we developed a physician and APP well-being hotline for people who were struggling with behavioral health issues or we set up a peer-to-peer support program where that was awesome. We had physicians, APPs, nurses volunteering, going, I want to help. Let me engage in this peer-to-peer. We have something called Code Lavender, which was if they were really experienced burnout, compassion fatigue, or others, we could get them formally into therapy with our behavioral health teams and that. And then we had, as I said, the peer support program, the monthly calls that were recorded, and they could go to our webpage and see any of those and listen to them at any time. Books to read, and then things around, like when the George Floyd situation happened, we set up immediately webinars with all of our teams to talk about it in a real way, about what they were feeling, how we were all hurting, and what can we do better as a healthcare system. So I just put those out there as examples. I think the key for us was transparency, and now we're coming out of it stronger. Everyone's tired. Our culture is still strong, and I think those were the keys through it.
I want to turn to Ernest and Will, but I want to ask you one more follow-up question on communication.
Sure.
During the pandemic, there were some disastrous breakdowns at certain healthcare institutions between senior management and the workforce, real hostility. And one of the most important things with communication is for people to believe, there will not be retribution if they complain, that people are genuinely open and not just saying they're open to hearing the feedback, and that they will act on the feedback and make change. So just, I don't mean to get you into another thing, but if you could just briefly tell us how you got that confidence from the workforce.
Well, I've been here 25 years. My deputy chief physician executive actually has been here a little bit longer than me. So we are known commodities, and people, believe me, they're not shy about reaching out. But I love that, absolutely love it. But for us, it was very important, and it still is, that if someone reached out, we closed the loop. Mm-hmm. We followed back up. And there was times where, we were getting 100 emails a week from people with suggestions, thoughts, concerns, et cetera. And we developed process and procedures to make sure that every single one of those got answered. And then we asked permission to bring those up and send communication out in the daily brief that went out, or to discuss it at my weekly calls. We really doubled down on that. That's how our leadership team leads. And I think people saw quickly through the pandemic that it was welcome, and there was no retribution around it. And it is the culture we have. I'm proud of our organization. Obviously, this isn't a commercial for us. A lot of people are doing it very, very well, but we have a culture where transparency and feedback is encouraged.
Thank you.
To back Scott up here, so the healthcare executives we work with, we use technology to gather feedback. So after someone works a shift, they're able to rate how they like their shift, and there's a form they can fill out, and we anonymize the feedback. We gather that data and we present it to our healthcare executives, and they love it. I mean, they're using it, just like Scott said, to help their own culture. This is coming from contractors working within their culture, but we do this quarterly with our executive teams of the healthcare systems we work with. And I think that's key. Like Scott said, we have to listen. And then you have to show the folks that have given you the feedback that you're listening. And in my career as a nurse, I felt like I was never listened to. And so I think that is a big key here, listening, and then showing that you're working on the problems.
That's great. Ernest, pick up on any of those points. There's a lot to unpack there, but I'd also like to ask you if you can talk about the need to rethink how work is distributed in terms of not between different nurses, but also with social workers, with whatever.
Absolutely. Well, thank you. And Scott is doing what I encourage chief nursing officers and other hospital administrators to do, is to actively listen to your staff, and he is closing the loop by going back and following up with them. That will tell you so much about your culture and your environment. To usually, if you have a nurse that's been there 5 years or longer, they consider that family. And when family's hurting, they want to know, what can I do to help? And, by soliciting those answers, or as Will says they're doing, by providing an evaluation of how this shift went, or what could have made it better, or, what tools did I need to, that wasn't there. It's one thing if an administrator gets that and does nothing about it, because that's going to further create more instability, if you will, at the core bedside. Versus if they actually listen to it and make change, that's going to improve morale. Now, your question about what are some of the issues, or how can work be redistributed, or one of the things also that I think Scott mentioned was, or maybe it was Aaron, about the electronic health record. Just about every nurse that I talk to says, there's good things and bad things about it, but the fact that you spend so much of your time justifying what you do or did not do, because if it wasn't done, then, if it's not documented, you didn't do it, and therefore, you're going to get dinged for it one way or the other, or
you can't bill for it.
Right, or you can't bill for it, absolutely. And so that's the big thing. So maybe we need to look at using some exceptions to, to that, or look at things that other members of the healthcare team can do that nurses are already doing, such as collaborating with social workers, as you had mentioned, or whatever. As nurses, we've always wanted to take this on. We can do this, we can do that, and et cetera. But maybe it's time to sort of divide our jobs up, and instead of trying to be everything to all people, maybe a distribution of the things that we are doing would make things a lot more easier. And that way you're able to spend more time at the bedside with the patient and get to know them a lot better, and what are their needs, and such as working with a social worker. If you know that so-and-so is going home, but there's no running water, there's no, I don't know, whatever else may be there, then, yeah, nursing can try to intervene, but a social worker may know other resources out in the community far better than a nurse would, that could coordinate all of that. And, so that once that patient is discharged, they're not going back into an environment that's going to trigger them to perhaps have readmission. Instead, they're going to be going home to an environment that has been investigated for them, and any stumbling blocks have been, moved out of the way. So maybe, yes, we do need to rethink that model of a redistribution of some of the things that we as nurses do. Not only for our patients, but even as nurses themselves. Sometimes during the pandemic, we were running on a nurse is a nurse is a nurse, and that's not necessarily true. A nurse who works in an ICU, you've got to be able to hone their skills or what their needs are, compared to a nurse who maybe is working in labor and delivery or in psychiatry or just on a regular med surg floor. And I'm not putting a hierarchy there. I think wherever a nurse is working, his or her skills is crucial to that area. But you can't just take, a nurse from, part A and put them over here in part B and expect them to do the exact same thing that someone who specialized in part B does. That's not the way it works. And so yes, we perhaps do need to look at how can we redistribute our workload so that we're able to provide better care for our patients, and also help to further reduce burnout among the staff.
Erin, there's a lot for you to pick up on here.
Yeah.
Can you talk about any of the earlier points also, but the work distribution challenge? I mean, who has to be involved in this decision making to make it happen? How difficult is it to get this kind of reorganization of work between different staffers and different departments?
Hard. No, so this is what our center focuses on, is sort of teams, right? So Ernest, I would say to you, in the midst of a nursing crisis, we need to be looking very carefully at what our nurses are doing. So why are our nurses ordering food for patients? Why are our nurses transporting patients? Why are our because we have a supply that's in scarce, an absolute resource that's in scarce supply. So trying to figure out what is the stuff that the nurse should be doing, and what could we engage other team members? So one of the things we're seeing is a growth of not registered nurses, licensed practical nurses back into hospitals to be able to actually practice with the nurse with more team-based nursing models. And then, as you say, integrating the social worker in to be able to help around discharge, but also social workers play a lot of clinical roles themselves that could be functioning on these teams, as well as dealing with burnout on teams. And we know from the literature that health professionals practicing in teams, full scope, also to your point, Scott, in environments in which there's shared governance, actually have lower burnout rates. The literature, the data are clear. And one of the things that we see for physicians in particular practicing on teams is that when they're practicing on teams and can refer to a social worker for sort of complex behavioral health needs or social risk management, they feel better, that their burnout's lower because they know that the patient will be cared for. So Liz, this question, I just want us to make sure we look at it holistically, but it really requires asking the team members themselves, but also organizing the delivery of care around patient services rather than professions. We always talk about how many nurses, how many doctors, but what is it actually that the patient needs, and what's missing from patient care, and who's the provider that could potentially provide that? It sounds so fundamental, but we sort of have to turn this discussion on its head. I think it's incredibly important. I want to also raise something that Ernest just raised. So one of the things we're seeing in our center's work is we have to also segment our strategies across the life course of a health professional. So those nurses who just graduated, let's just use nurses, but you could substitute physicians, pharmacists, whoever. Those nurses who just graduated during the pandemic, in fact, graduated at a time where they may have not been able to do full clinical placements. They may have had a situation where they feel underprepared and they're entering the workforce feeling underprepared. And so those younger nurses, those new grads need a whole lot more mentoring, a whole lot more touch points. And Scott, to your point, Atrium had these pieces in place before, but it's like enhancing them. So we're supporting them. They may also not want to be on your health insurance because they're on mom and dad's health insurance. So just give me the cash, thanks. And so really thinking about the segmenting it to the interventions that you need for new grads. But then one of the things our research is showing right now is those early to mid-career health professionals, they're in a squeeze because they got childcare, they may have elder care, their careers are just on the up. And it turns out that that group who's sort of been practicing 11 to 20 years, or even sooner than that, are facing emotional exhaustion. And they are actually the most likely for physicians to either exit medicine completely or switch from clinical care to something else. And so what we see is sort of, how do you target supports? And a lot of it's scheduling flexibility. And some places are doing 7 days on, 7 days off, for nurses having scheduling flexibility for those early to mid. And then those mid-career people, maybe looking at role changes. Look, I've been doing this clinical care thing for a while. I'm ready for leadership. I'm ready for a non-clinical role. I'm ready for some. So really, looking for role development for them. And it may be leadership roles as well. And then the group that fascinates me the most, and you guys have alluded to this, Ernest, you in particular, like, what do you do with this group of this bolus of about to retire nurses? It scares me. Our work does show our shortage in North Carolina doubles if nurses exit the workforce 5 years earlier, doubles. So how do you keep these seasoned nurses in practice, or these seasoned physicians? And one of the things we've been looking at is interventions targeted towards moving them to virtual care. They don't want to do clinical care anymore. We'll have them do virtual care, so they're still doing patient care, right? Scott, they're still connected to the patient. But the other thing is we've got a crisis in nursing that we don't have enough faculty. We don't have enough preceptors. So how do we have academic practice partnerships to be able to have these hospitals partner with academia to create faculty from clinical practice into academia? So I just sort of want to highlight, it's not just a task shifting, it's also a shifting of how we approach what we're doing to where we are in the health professional career. And I think Will sort of alluded to that. This is not your, grandfather's workforce anymore. This is an on-demand workforce, and they're going to demand. So that's some of the work our center has been doing, is sort of understand these interventions across the life course.
Thank you. And I want to get back to teams later in the conversation, particularly as it helps workplace morale and the issues of violence. But Will, I wondered if you can talk a bit about, so we have a stressed out workforce where you're all talking about, nurses want more flexibility, different points in their career. Some may want to be floating nurses, or you have a staff that needs to have time off, but you've got nobody to back them up. So we have to create these floating workforces. But traveling nurses have created a problem if they're state to state. They cause resentment because of their higher salaries, et cetera. Can you weigh in on that, about what is the best way to use a floating pool that sort of keeps the continuity and quality of the care moving, and then also takes the pressure off some of these nurses who need more flexibility depending on where, maybe they have childcare issues, et cetera, that this would give them more flexibility?
Sure. I want to just add to Aaron's point here. A lot of the people we see working in these really flexible roles, they are the retired individuals. They'll go to Europe 1 month, they'll come back, they'll work. But, the thing I'm proud of is we've been able to keep them in the industry. And that is our main focus as a company. It's like, how do we keep these folks in the industry? These mid-career folks, they're thinking about going to other careers, right? The new grads can't. They've only been working for 6 months. But I'm talking to new grads who are already talking about leaving nursing in a year. My friend who works in California, she's already fed up. And so it's really about like touching these people's wants and desires. And we have people creating LLCs and C Corps, starting IV businesses. There's entrepreneurs here. So that's where the labor's at. And now going on to the healthcare systems and talking about continuity of care and creating flexible pools, travel. I'll be frank, travel nursing makes zero sense whatsoever. You're taking one population in a city and you're moving it to another one, and you're taking that population in a city and moving it to another one. And the only folks that gain from that are large staffing agencies who've been living on this model for the last 20 years. And kind of the nurses, they don't get paid that much. A lot of it goes to these staffing agencies. And so, well, when we're working with healthcare system executives, they're talking about how do we access this local labor force? How do we get people that want to work 6.7 shifts on average a month, get them in working for us consistently as a per diem pool that works, 6.7 every month for us. They work in this particular unit. And then we don't need all those long-term travel contracts. And we don't have to get a bunch of med-surg nurse travel contracts or ICU nurse travel contracts. We have this really reliable group of people, maybe it's 1,000 folks that work for me, in my 8 hospitals in St. Louis, and they work for me every month. And I'm getting really that labor to come in and give my own full-time staff a break when they need it. And I'm getting, those holes filled. Now to do that, you have to have technology, because not only are we short on the nursing side, but we're short in the operations side, we're short in human resources side, like we're short everywhere. And so you can't have a bunch of folks using Google Sheets and telephones and text messaging and emailing to schedule 1,000 people for an average of 6.7 shifts, right? That makes zero sense. So you got to have like a workforce solution that integrates into your technology stack that makes your operators' lives easier as well. So the repetitive tasks need to be done with technology. And so that's really, what I'm seeing as a focus and how we really get to this flexible local labor pool working, which meets the needs of the professionals and the healthcare systems alike.
Scott, there's been a lot of points mentioned, and I want to let you get in on a number of them. Would you like to talk about work distribution? Do you want to talk about what would you like to do?
Yeah, no, I'll just touch on a couple points. I completely agree with both Will and Aaron, those last points about how we not only recruit, but retain. We have to retain people we have, because the ones who are still with us are the ones who are our family and in this for the long haul with us and have endured, the past several years and everything else. And my goodness, what a shame to lose them through this. So really the focus on retention is a significant thing that we have to do. And we know that people, if all things being equal, will often leave for just a couple more dollars an hour. But the key is to make all things not equal, right? You have to make them feel that they're part of something larger than themselves. You have to value their feedback. You have to show that you value them through your daily acts and those type of things as well. And you have to obviously pay a competitive rates, but we're never going to win this the staffing situation just by paying more. You have to retain the ones you have, and that comes through culture. The other thing I would just touch on, and Will sort of hit on this a little bit earlier when we were talking about communication. One of the things we switched to get feedback as a system was we went away from the yearly sort of big engagement surveys that so many of us have done forever. And if you're like us, when we used to do those, you spend 3 months preparing for the survey and trying to remind everybody of everything you did. And then you get the feedback back, and then you figure out action plans around it. That takes another 3 months. Then you have about 6 months to actually do something before you're planning for the next one. And it's this cycle where you're not getting real-time feedback, and you're also sort of chasing your tail a bit. We moved to what we call anniversary surveys. So every single one of our teammates, we call our employees teammates, get on their anniversary of their hire, gets a survey. It's a standard survey that is sent to them. And, I'm not sure where we are now, somewhere between 60 and 70,000 teammates within Atrium Health. So we are getting hundreds a month, if not thousands a month of surveys done, anniversary surveys done. And it's real practical stuff. And we look at that on a consistent basis. My boss, our CEO, demands that as part of every one of his direct reports, monthly meeting one-on-one with him, that we are reviewing the results of our annual surveys and acting upon it. And he also insists, and we do it, that we do that with our teams. We cascade that. So it's a culture of continual improvement based off of the anonymous feedback that we are getting every single day from our teammates. And then we build action plans. We build our strategies and our goals based off of closing the gaps in the themes that we get. So that is something in regards to communication, and building that culture of transparency and feedback. The last thing I would say that Aaron touched on in regards to flexibility too, and which is so key to retention. Virtual is a great enabler of this, and we have done exactly what you said, Aaron, with a lot of our nurses and that we're looking to retire. We have engaged them virtually, and they can do so much virtually, and it's great to have the second set of eyes if that's what they're doing. We can do virtual sitters for our techs and those type of things, give them that flexibility. And for our nurses, especially the ones that have been with us a while, there's such a wealth of information for our teammates. That has been a huge success. So I think that flexibility and how we utilize the team is incredibly important for retention.
Thanks, Scott. In fact, this issue of retention versus recruitment is really resonating with the audience, who feel that their healthcare systems may be focusing too much on the recruitment side and not on retention. I know, Ernest, you raised a really important point, yes, which is ask people what would make them stay, and not why are you leaving. So can you talk about that?
Oh, absolutely. It all goes back to communications again. And, it's important, as if I am in the C-suite and I want to get a pretty good idea of what the culture of my organization is like, then yes, ask that long-term person there, what keeps you here? What are some things that, you'd like to see, perhaps improve, or what are we doing good? What are we doing bad? To sort of tie in with the comments of Will and Scott when we're talking about travelers. One of the we know that it's a big dissatisfier for that long-term nurse that probably has been there, because he or she figures, onboarding this person, they're only going to be here 3 months, but they're going to and obviously they're making more than I am probably. But I also have to be responsible, because they don't know all the policies and procedures and things like that the institution has. And once they do learn that over that 3-month period, they're gone. So it's going to be an even more brain drain, if you will, from the institution, and it's going to benefit their next employer and the next employer and the next employer. So you're really investing quite a lot there. So it is important that we focus on retention as well. And as I said, just by asking that long-term employee, what it is, what would make you stay, or rather, why are you leaving if if they're choosing to leave? But what are the good things that are going on here that that keeps you here, and play up on that, and and do put in place whatever it may take to retain those older employees as well, because they're your most loyal employee. One of the things that I frequently hear all the time is, you're spending all this money on travelers, but what are you doing to to retain me here? The occasional movie ticket, or the the coffee and donut and the pizza party, those are those are out the window. They went out the window a long time ago. I want to know that I feel valued. And of course, feeling valued for one long-term employee is different for a newer employee. A long-term employee, to feel valued, could be, hey, you don't have to work weekends anymore, or instead of working maybe do 8-hour shifts instead of 12-hour shifts, or some sort of tangible benefit that is that they value much more, that says my company cares about me enough that they're willing to do this for me. Well, I'm going to go to bat for them as well. And and when there is a staffing shortage that needs, or a hole that needs to be filled, I'm probably going to feel more obliged to step in and volunteer to fill that that one shift or 2 shifts than if I knew that the employer was not doing anything to show that I'm a valued employee. I like Scott's term, the way they address their employees as well. That again makes them feel that they are part of the system, not just a cog in the wheel, but they are truly invested, and what happens to the system also happens to them. so you feel that connectedness.
And as you all have said throughout this conversation, different employees have different needs throughout their lives. For example, some communities, there's a housing crunch, and people can't afford a place to live. And so health systems, right, are now having to look into ways to assist with that, with affordable housing, or, she said more onboarding services for young nurses so they feel supported. So Will, do you want to jump in on some of these points?
I do. I think retention is key. Retaining people at your healthcare system is key. I think we need to reframe how we think about employer-employee. I mean, doctors are all contractors, but they stay at healthcare systems for 20 years, right? You don't have to employ these folks. There's a lot of them that don't want to be employees, and that's fine, but they'll work for you for 15 years. So I think the employee-employer relationship makes sense for a lot of people. It made sense for me when I was a new grad nurse. It made sense for me when I wanted to work, 3 to 4 days a week, every week. But it doesn't make sense for retired individuals. Like, if I want to go to Europe for a month, my wife's in Portugal. I want to go to Europe for a month and spend time over there. I should be able to do that and come back and still be able to work. And a lot of the traditional employer-employee relationships, whether it's due to unions, state laws, don't allow for that type of flexibility. And so that's really where we have to rethink this entire industry. These are licensed individuals by the state. We live in an age now where there's healthcare benefits for independent contractors. There's tax tools. Folks have their own businesses, and so I think really that's a big part of this. I mean, that's where I come from. I mean, the happiest day as a nurse, I can remember my career when I was an independent contractor working for an ambulance company, because I felt like I was my own business. So I think we really have to meet those folks as well, and kind of rethink the employer-employee relationship and talk about retention from a standpoint of people continuing to work for you that live in your local area, not just employed by you.
Thank you. Aaron, please pick up on those points. And then we have about 10 minutes left. I'd like to have you talk about the team's approach and dealing with workplace violence, which is another high stressor. But please feel free to first address any other points.
So I really want to pick up on this audience question of retention. So we created a workforce model called North Carolina NurseCast, and it's just for North Carolina, but you should Google it, because we in North Carolina had to convince our legislature and others, you can put out as many new nurses as you want, and let's wave a magic wand and pretend that we could increase nursing enrollment by 10%. We can't. We don't have the preceptors. We don't have the faculty. That only decreases our shortage by 11%. But if you actually have nurses, in our model show, if you actually have nurses leave 5 years earlier than they would have, it doubles our shortage. Just in terms of math, it is about retention. So I just want to clue your audience into the fact that you can go look at our model and say to folks, you can grow all the new nurses you want, maybe. Because the nursing workforce is so large, you're just going to be, it's sort of a short, it's just not going to make a big difference. But if you can retain that bolus, especially those older nurses, going to have a huge short-term effect. And so just the math, it's just down to the math. But workplace violence, I'm glad you asked about it. It's a huge issue. Dr. Brianna Lombardi in our research center just posted a synthesized literature search on our website that some of your audience may be interested in. 1 in 5 healthcare workers internationally experience workplace violence. The healthcare workforce makes up 14% of all workers. It makes up 75% of all non-fatal intentional workplace injuries. And those include patient to provider, but also provider to provider. Who's most at risk? It's a group we haven't really talked about today. The groups most at risk for workplace violence are nursing assistants, medical assistants, housekeeping, and social workers. In terms of demographics, a Bureau of Labor Statistics study of 6 years of data found that Black healthcare workers experienced injury rates 3 times greater than their white colleagues, 3 times greater. And, to this problem, is it a new problem? No. Workplace violence existed before the pandemic, but the data do show from BLS, the Bureau of Labor Statistics, that injuries that resulted in at least 1 day of missed work have at least doubled for workers in hospitals, ambulatory medical settings, and nursing homes. And so we've been thinking and looking at this workplace violence issue, and folks here already on the beginning of this panel talked about reporting. So there's lots of studies out there that I think it was Ernest who said, nurses report that it's actually even harder to report workplace violence during the pandemic because they feel so bad. There's so much going on anyway. I can't really report that. In one study, half of the staff indicated that they didn't report workplace violence to the administration. Scott, that probably doesn't happen at Atrium because of this open two ways communication. It's another reason to have that sort of transparency and openness. And so I guess what can we do? I'll be very quick because we don't have much time. I go back to the Paul Drucker thing. What gets reported gets managed. What gets measured gets managed. We've got to deal with the fact that sometimes employees don't report. If an employee does report, sometimes it's only if you missed a day's work that it gets reported higher up. There is just lots of reasons why we should collect and report these data so that we can more accurately assess the problem and then address it. Prevention is a huge issue. I know the Joint Commission is looking at this and trying to put standards in place. The American Hospital Association has the Hospitals Against Violence initiative. These are all really important things. But to your point, Liz, teamwork matters. Turns out that there is some evidence that working in teams is a protective, resilient factor for people, not just related to workplace violence, but in terms of wellness and feeling that they're part of a team, feeling that they're valued. And these things are incredibly important to retention. So those are just sort of some thoughts that bring together a couple of threads of conversation that we've had today during this panel.
It's also actually it's enforcing when people are. I mean, look, if you're a flight attendant and you get hit right now, I think you can. Isn't it a federal offense like TSA?
Mm-hmm.
Well, nothing happens.
That's the same
nursing. I mean, we need an actual way to.
Yeah, I'm sorry. There is an act out there that is being proposed called the SAVE Act, which is the Safety from Violence for Healthcare Employees, which really. Exactly, Will. I'm sorry, didn't mean to cut you off, but it's exactly what you're speaking of there. It's good. Yeah, it's giving healthcare workers the same protections that flight crews and airport workers and that also have. Which, my goodness, that should be a no-brainer. Yeah. And we all went in healthcare, nurses, doctors, APPs, others. We knew there were going to be long hours. We knew there was going to be heartbreak when patients had bad outcomes. We knew we were going to put our hearts and souls on the line there. We did not think that we were going to be unsafe. And that is something we absolutely have to do everything we can as not just healthcare leaders, but as a nation to protect those who are caring for us at our most vulnerable. And we are studying this as well. And we're seeing we're seeing a significant increase like everyone else, but about 90% of it has a linkage to behavioral health. Mm-hmm. And so we have to address behavioral health within our nation and the resources available, because that is what we are seeing. I'm not saying it's patients that go to our behavioral health hospital, but the violence or the acts that are occurring are related to a behavioral health condition that is being expressed.
I'm going to ask Ernest to give the final comment on this, but I want to say that thank you all, because you just raised something the audience has raised about safe staffing laws and to protect the healthcare workforce. I'm very glad that you mentioned it. Ernest, Aaron mentioned that Black healthcare workers are the largest targets for violence. Mm-hmm. So can you talk about what we do about this? Does the team's approach help? What are other things to do to limit the negative impact of bias on the healthcare workforce?
Yes, thanks. And Erin is correct. With her, reporting the study, Black and other people of color are, really more assaulted, and it boils down to essentially. As we've been talking about, whether or not they have the support of administration, when they go to report these incidents, and whether or not they're talked out of it, or if you have the policy and you say it's a zero tolerance policy, you should enforce it all the way. to get to answering about Teams, because I realize we're very short on time. But yes, I think Teams is a way that we can help to address this. When I started in nursing, we were using team nursing, and it worked very, very well to be able to meet all the needs because of the distribution of the work that was done. You had an RN who was sort of head of the team. You had the LPN who was doing medications. You had RNs and LPNs, doing patient care, and it was all very well organized, and it was very efficient, and you got the workload done. That doesn't seem to be the case right now, as although some hospitals are going back to that, they're finding that it is more time efficient, and also less stress on the staff as well. That they're if it's organized just right, all those checkbox on the EHR gets done, and everybody's happy. But it's a matter of making sure that it is run very smoothly, and it will take some time to get that implemented, or up and running. So, but it is a great way to, something to look at. The other thing that a lot of facilities are looking at now is reducing, instead of doing 12-hour shifts, going to 8-hour shifts as well, as another way to help combat not only the fatigue and mental and physical fatigue that nurses are experiencing, but it also, studies shown that when you are well rested, you're going to be much more on the top of the game. Your critical thinking skills are going to be at peak, and et cetera. But when you're doing 12-hour shifts, especially 3 and 4 in a row, and we know that 12 hours quickly turns into 13 or 14 hours. So by the time you get home, you have dinner, you go to sleep, and you come to work on 3-4 hours worth of sleep. That's not good for anyone, not only you, but it's not good for the patients you're going to be assigned to care for as well.
Thank you all. This has been a really engrossing discussion. I'd like to thank our outstanding panel, Will Patterson, Dr. Scott Rissmiller, Ernest Grant, and Aaron Frere. Hopefully some of the best practices that you all touched on here will continue to gain more traction nationwide and alleviate the stresses being felt by our healthcare workers, many of whom provided truly heroic services throughout the pandemic. I thank you all.
Thanks.
Thank you.
Thank you, Liz. Thanks.